Thanks, Al. Okay, I've come to the last talk, and thanks to all of you for staying. I guess it's maybe a little bit of a surprise for you guys to know that surgeons have anything to do with Parkinson's disease, but we have, and we've actually been doing something about it for a long time. It's just that we've lately got some good results, so we've got to tell you about it. You all know all about the biochemistry behind Parkinson's disease, so I won't belabor the point here. And medical therapy is still the mainstay in Parkinson's disease. Now, the point here is that Parkinson's disease does progress, and there comes a point when there is a place for surgery to palliate the disease in combination with medicine. Now, this series of pictures is taken from Dr. Netter's famous book in neurology, essentially to illustrate some of the stages in Parkinson's disease, and just to help understand, this is the Hone and Yahr staging. In stage 1, the disease is unilateral, usually presenting just early on with tremor, and stage 2 simply it just progresses to bilateral disease. In stage 3 is when you start getting the postural type problems, but the patient is still able to function independently. In stage 4, what happens is that the patient, although still responding to medicine, is unable to care for himself, so he more or less needs a carer around most of the time. In stage 5, he's no longer responding to medication and is basically bedbound. So the point of all this is that we mainly confine our attention to patients in stage 3 and stage 4. This is a surgeon's understanding of how disease progresses in Parkinson's disease, essentially very simplified. Winglock has got a much more detailed idea, but where we are going, in the early stage, disease is very responsive to medication. You may need 3 doses a day, and the patient remains within these green lines, which represents effective control of disease. And then as disease progresses, the number of doses has to go up, but you still have control. But once you enter stage 3 and stage 4, you get complications. Now, the disease in complicated PD basically fluctuates between hyperkinetic, normal function, and hypokinetic. Now, this is just a video to show you what it's like when someone has dyskinesia, all right? Basically, it's uncontrollable hyperfunctioning movement there. And there are many varieties of this problem. So that's a dyskinetic patient, all right, when his response to the drug overshoots into this zone. Now, this is a patient when he undershoots this way, all right? This is what it looks like in the off state. Okay? You can see it's his ability to walk is actually very impaired. He freezes. You can see him getting stuck there. Okay? And so essentially a patient in complicated disease is going to vary between these sort of stages to different levels of severity. And the point has been made that over time, almost everybody runs into complicated PD. But again, not everybody has complicated PD that's difficult to control. Our understanding of what happens in the brain in Parkinson's disease has actually advanced quite a lot. A lot of the understanding actually happened after we discovered this chemical, which was found to make drug addicts Parkinsonian. It was a contaminant in LSD. It was discovered in roughly around 1985. And then we were able to then give it to monkeys and come up with a Parkinsonian monkey. And with that, the circuitry in the basal ganglia was elucidated. And essentially, this is a very complicated pathway, but essentially, dopamine from the substantia nigra enters into a circuit. And the point here is that the normal circuit is disturbed in Parkinson's disease. And essentially, you have a couple of points where nuclei are hyperfunctioning. The points that we're talking about is this point, the subthalamic nucleus, the globus pallidus, all right? And when we talk about surgery, we are basically aiming to affect the function of these nuclei. We're not doing anything about the amount of dopamine in the brain, but rather we're smoothing out the circuit. This is a path slide, and this is the corresponding MRI, just to remind you where these structures are. This ribbon here is the cortical gray matter, and in the center of the brain there's another mass of gray matter. This is the thalamus, all right, around the ventricle, and just to the side of it is the corpus striatum, which the putamen and globus pallidus here, all right? Between is the internal capsule, and you can see on the MRI, you can actually see these structures very well with the layers between them. Then again, you can see the subthalamic nucleus. This is a nucleus that's below the thalamus, all right? Just about here, and again, you can see that on an MRI. Now, what is the point of all this? It's basically that with this knowledge, there is now actually a very scientific basis for what we're doing in Parkinson's disease. We've got a coming together of various things. Neurology inputs, understanding in neurobiology, in neurophysiology, neuroimaging, and also safety in neurosurgery, because we're using computers to navigate. And so we can have predictable, good results. Now, coming into a little further into what we do, the point that I want to make here is that all this is done as a team. Now, if you look at the what is actually recommended in the CPG, surgery doesn't have a very prominent place. It has a place, and the point is that we function within the team, and the neurologists are essentially the gatekeepers, all right? They will select the patients. The neurologists that I work with, Dr. Lewis Tan, E.K. Tan, Winglock, who just spoke, and essentially there's a team that essentially selects patients, and eventually when suitable candidates are identified, then only do we get involved, all right? The surgeons involved in the National Neuroscience Institute are myself and Dr. Ng. Now, this is just a video to show you a patient who surprised me. This is, again, like the heading shows, to show you that surgery can be effective. He's now in the stage without medicines. He's been off medicines for about 12 hours. He can't get out of a chair, okay, on his own. And essentially, when he came to see me, he was in a wheelchair. I thought essentially he was in stage 5, but I was convinced that he wasn't by the team. And this is him. Again, he's without medicines, and after we've put in a couple of stimulators, he's now actually able to stand up on his own, all right? And you can see him start walking. Now, this is him without medicines at all. He's been without medicines for about 12 hours. Okay? He's actually improved a lot more than this, because he's had a couple of sessions where we've managed to program his stimulator. Okay? And he's doing much better. But just the point that the stimulation actually makes an immediate effect on the disease. A little later on, you can just see him jumping out of the wheelchair. Just a couple of seconds. Just bear with me. Okay, this is him doing what he couldn't do before. All right, he got out on his own, and he's no longer on medicines. And this is him now. After adjustments, he's on half the medicine that he was before. All right, and running with a stimulator. So you can imagine that he's actually been palliated quite a lot. All right. Just a short history. Surgeons have been interested in doing something with Parkinson's disease for actually a very long time, but in the early stages we were doing some massive surgery which, predictably had high morbidity. People were cutting out bits of cortex, operating the spine, operating the basal ganglia, and this is had some results, but essentially a lot of side effects that gave surgery a bad name. The essential advance came in about 1947. When Spiegel and Weisses developed this stereoencephalotome. This is the picture of what it is. It's basically a device that allows needle-type procedures so that we can target individual nuclei. And this is where we're at right now. We are talking about needle-type procedures directed at individual nuclei. So we're aiming either at the subthalamic nucleus or the globus pallidus internus. So there's a contraption to carry the needle, but the needle is directed towards a particular nucleus which we can target using MRIs. Again, just to demonstrate, this is a patient with tremor. She's got a stimulator, and The hand you see there belongs to Dr. Tan, and he's now turning off the stimulator. And you'll see her left arm starting to shake. Okay? And this is her tremor has come back. This lady lives in JB. When she came to us, her main aim in life was to go back to gardening. All right, and her medication was not controlling her symptoms, and her symptoms are essentially bilateral. So here you're just seeing the unilateral problem. The stimulator is now being turned on. And you can see the tremor stops. So with this, now she's got actually 2 wires in her head, and she's now able to function pretty well. She's now about 3 to 4 years after we've put the implants in, and functioning quite happily. Her jaw tremor has been a more difficult symptom to control, but otherwise she's been happily functioning. Yeah. Now, what are surgical options? Now, we're talking about basically interfering with brain nuclei. So traditionally, it's been a lesion, meaning we just destroy that nucleus. And much more recently, we try to modify the nucleus. Now, this is a patient from Bangladesh in whom we did lesion surgery. We destroyed his globus palatus internus bilaterally. Here you're seeing him again without medications for 12 hours. Essentially, he's fairly bradykinetic, not too bad. Okay? And when you look at his feet, when the video shifts down, you'll be able to see that he's got a very painful dystonic posture in his foot. All right? And this is something that's fairly common in the more advanced stages of Parkinson's disease. Early morning, they get dystonia and cramps and pain. And at this point, we're asking him to get out of the chair, and again, he can't. All right? Now, the next segment is after we had created lesions on both sides. All right? This is him again. He's without medications. It's now about 7 to 8 years since we've done this, and he's basically been in good functioning status. All right? You can immediately see that his bradykinesia and rigidity have been addressed. Okay? Look at his feet now. Okay? The dystonia has been relieved. Okay, and much more important to him in terms of the quality of life is that now, even without the medications, he could, as you can see, he could get out of his chair. Okay? So this result basically allowed him to get back to work. He was a manager in a company in Bangladesh. And like I said, he's now about 8 years down. I think he's retired from his job. Now, therefore, if we had effective results with lesions, and this is a CT, I mean, this picture basically represents what we do. To create a lesion, you put the probe in the target, and you use electricity to create heat to coagulate the target. So in the end, you get a lesion. This is a coagulum in the globus pallidus internus. But why deep brain stimulation? Now, if we compare what we're doing, it's essentially a philosophical point at one level. In Parkinson's disease, you have a degenerating brain, and you really don't want to destroy any of it. All right. So if you compare the 2 types of therapy, stimulators are non-destructive. Essentially, you're dropping a wire into the circuit to interfere with it with the electrical pulses. Lesions are irreversible. Once you burn something, it's gone. Stimulation can be modified. It can be switched off if they don't like it. But then again, here at another level of the argument,